Good evening, everyone. You will, of course, hear the dings as people come in, and I'll admit them as they come in. This is Tuesday evening, and we're doing Module 2. So you will recognize this screen because this is the first page of Ahip every time you come into it. And you're going to click on the 2025. And if you look at this circle, it's 0% completed because I haven't done all 5 modules. So the first module is complete. We're going to module 2 tonight. And we are recording. And if you miss the live or there's some parts that you need to review, you can go to my YouTube channel, go to YouTube, put in Faye Horton, and my YouTube channel, the way you'll know that it's the right one is I have on that blue dress with the mic in my hand. So there you will find the recording for each of these trainings. So in Module 2, you're going to learn about these things. You'll be able to explain that under the Medicare Advantage program, private companies offer health plans that cover all Medicare Part A and Part B benefits. You'll understand who is eligible to enroll in a Medicare Advantage plan and the possible premiums that might be entailed. You'll be able to identify the Medicare Advantage plan types: coordinated care plans, private fee-for-service plans, and medical savings account plans. You'll learn about special needs plans. Those are your SNPs, the various types of SNPs, and who can enroll in them. We'll explore the various types of Medicare Advantage coordinated plans that include health maintenance organizations, your HMOs, your health maintenance organizations with point of service, your HMOs with POS, and the preferred provider organizations, which are your PPOs. You'll gain an understanding of the MSA plans, including what they do and do not cover. You'll learn about the types of coverage that employers and unions may offer retirees and their dependents. You'll understand that individuals who qualify for both Medicare and Medicaid are considered dual eligible, and they can choose to enroll in Medicare Advantage plans. We will explain how Medicare Advantage enrollees may obtain prescription Part D coverage through coordinated MAPD, Medicare Advantage plans with prescription drugs, of those who enroll in MSA plans through standalone prescription drug plans. We'll review other types of Medicare plans which are not Part C Medicare Advantage plans, including the Medicare cost plans, PACE plans, and the Medicare Medicaid MMP plans. We'll also identify the protections afforded to Medicare Advantage enrollees through the grievance and appeals process. Module 2 is required. Part C and other Medicare health plans. Every night you will see these instructions, and every time you come to a module, you'll see the same instructions. So those are your navigation instructions, and they pertain to the buttons down here, previous, next. If you have to go forward, if you have to go back, those will always be the same for you. Of course, This training program is protected under the United States copyright laws. It's not my program at all. It's the Ahip program. I'm just only giving you the information that's in the program and pointing out the key important pieces of information that you might need to remember, particularly for your testing. These are the learning objectives for Module 2. Explain what types of Medicare health plans are available and who is eligible. Describe the different types of special needs plans. Describe features of different Medicare health plan types. Describe the different types of benefits offered by Medicare Advantage plans, and explain how Medicare health plans work with prescription drug plans. And as usual, when we're done, we will stop the recording. You can then, the floor is then open for questions. If it goes over an hour, that's okay, but it should maybe take about an hour. If it goes over that hour and you have questions, don't feel that you cannot ask them, ask the questions. And when we're done, do the practice test. If you're already in Ahip,
I'm do, this moment.
Do the practice test as often and as many times as you may need to until you have all of the answers correct. The one thing, Nikisha, that I wanted to tell you is that if you do the practice test again, you may have different questions. So we're not all going to have the same questions, but if you've taken the test more than once, when you get to the final test, the questions that are going to be on the final test are going to be ones that you've taken. So you should feel comfortable in taking the final test after we complete Module 5. So Module 2 has 11, it looks like 11 pieces. Medicare Advantage plan types, coordinated care plan, special needs plan, Medicare Advantage plan types, private fee-for-service, Medicare Advantage plan types, Medicare savings accounts, Medicare Advantage employer, union plans, Medicare Advantage eligibility, cost and benefits, Medicare Advantage plans and qualified Medicare beneficiaries, Medicare Advantage and prescription drugs, other types of Medicare health plans, and enrollee protections, appeals, and grievances. Under the Medicare Advantage program, known as Medicare Part C, private companies offer health plans that cover all Medicare Part A and Medicare Part B benefits. That's a requirement for the plans. And anytime that you see a Medicare Advantage plan that's offered by an insurance company, it has already been approved by Medicare. The insurance company cannot just create a plan and put it out on the street. Medicare still controls who has the plan, where the plan is offered, and Medicare does that to control the fact that there may be too many plans in a certain area and not enough plans in other areas. And each Medicare Advantage plan, just for your information, needs to be supported by a provider network, which includes the hospitals and the primary care providers. Many Medicare Advantage plans also cover Part D prescription drug benefits. All Medicare Advantage plans have a maximum out-of-pocket, the MOOP, for basic benefits. Those are covered medical benefits, Medicare covered benefits. Many Medicare Advantage plans also offer additional benefits that Medicare does not cover, known as supplemental benefits. The types of Medicare Advantage plans are coordinated care plans. These plans have a network of preferred providers and include your HMOs, which is your health maintenance organizations, Some are HMO POS, so that means they have a point of service benefit that does allow beneficiaries to go out of network subject to certain limitations for some benefits. The preferred provider organization, which is your PPO, the private fee-for-service plans, and the medical savings account plans. So those are all your Medicare Advantage plan types: HMO, HMO POS, PPO, PPFS, and MSA. HMOs generally only cover services furnished by doctors and hospitals within the plan's network, known as participating providers. HMO enrollees may need to select a primary care doctor and may need a referral for specialty care to be covered. Some HMOs offer a point of service option that allows enrollees to go out of network for certain services with doctors and hospitals without receiving prior approval for those services. And in most cases, those services are going to have higher copays. Unlike a PPO, an HMO POS plan may limit the services available out of network or may put a dollar cap on the amount of out of network coverage. Cost sharing is generally higher for services that are out of network in the HMO POS, which is what I just said. These are the exceptions. These are exceptions to the HMO or the HMO POS. Emergency services furnished by out-of-network providers are covered. When the enrollee is temporarily absent from the planned service area, dialysis services are covered outside of the network. Urgently needed services furnished by out-of-network providers are covered when the enrollee is temporarily outside of the service area or in rare circumstances when the network is not available. If a needed specialist or covered procedure is not available through a participating provider, the HMO plan may authorize out-of-network services. These are your coordinated care plans, the PPOs. Under PPO, enrollees may get care from any provider in the United States who accepts Medicare. They're not limited to participating providers. So they can use providers that are in network or providers that are out of network. They do not need a referral to see someone that is out of the PPO's network, but they're encouraged to contact the plan to be sure the service they wish to obtain out of network is medically necessary and will be covered. There's usually a higher cost, a higher out-of-pocket cost for the individual to receive services from an out-of-network provider. Regional PPOs are PPOs that are offered throughout an entire region can be made up of one or more states. Coordinated plans, special needs plans. Special needs plans, which we call SNPs, are a type of Medicare Advantage coordinated care plan, HMO or PPO, and they're specially designed to serve a subset of Medicare beneficiaries. In addition to meeting all other Medicare Advantage eligibility requirements, beneficiaries must also meet the specific type that the SNP is for them to enroll in that particular SNP. All SNPs must implement an evidence-based model of care with appropriate networks of providers and specialists designed to meet the specialized need of the plan's targeted enrollees. All SNPs, all SNP plans, all special need plans will include prescription drug coverage. There's more than one type of a SNP, and the first one that we're talking about tonight is chronic. There are several types of special needs plan. Chronic conditions are SNPs that restrict enrollment to individuals with certain chronic or disabling chronic conditions, such as diabetes, cardiovascular disorders, cancer, certain chronic lung disorders, HIV, dementia, end-stage renal disease, requiring dialysis, or certain other conditions. Each chronic SNP will specify the condition or conditions necessary to be eligible to enroll. They're not the same per carrier. Every carrier's chronic plan specifies the chronic condition required for their particular plan. Institutional SNPs, I-SNPs, are SNPs that restrict enrollment to Medicare Advantage eligible individuals who, for 90 days or longer, 90 days or longer, have had or are expected to need. Someone needs to mute their mic, please. Thank you. Institutional SNPs, I-SNPs, are SNPs that restrict enrollment to Medicare Advantage eligible individuals who, for 90 days or longer, have had or are expected to need the level of services provided in a skilled nursing facility, a nursing facility as defined under Medicaid law, an intermediate care facility for the individuals with intellectual and developmental disabilities, a long-term care hospital, an inpatient psychiatric facility, or certain other facilities specified by CMS. Institutional equivalent SNPs enroll Medicare Advantage eligible individuals who live in the community but require an institutional level of care. An example, they're determined by an impartial entity to need the level of services furnished by the type of facilities listed above. Eligibility for an IE SNP may be limited to certain assisted living facilities. Chronic SNPs are your regular SNPs, your I-SNPs, and your IE SNPs. Dual SNPs. Your D-SNPs enroll certain categories as determined by each state of dual eligible beneficiaries. Dual eligible beneficiaries are those who qualify for both Medicare and Medicaid. They include beneficiaries enrolled in Medicare Part A and or Part B and receiving full Medicaid benefits and or Medicaid assistance with Medicare premiums or cost sharing. The categories of dual eligibles include QMB, qualified Medicare beneficiaries. Those are Medicaid, where Medicaid helps to pay the premiums, the deductibles, the coinsurance, co-payments for Part A, Part B are both programs for these beneficiaries. SLMB, specified low-income Medicare beneficiaries. Medicaid pays Part B premiums for these beneficiaries. QIs, qualifying individual. Medicaid helps pay Part B premiums for these beneficiaries. QDWIs, qualified disabled working individual. Medicaid pays the Part A premium for certain disabled and working beneficiaries. So your categories of duals are QMB, SLMB, QI, QDWI. Dual eligible individuals may also be eligible for full Medicaid, and they're known as FBDEs, full benefit dual eligibles. Continuing with D-SNPs, fully integrated dual eligible D-SNPs, which provide dual eligible enrollees coordinated access to Medicare and Medicaid benefits, including Medicaid, primary care, acute care, and long-term services and supports under a single organization that has a Medicare Advantage and Medicaid managed care contract. D-SNPs can also include highly integrated dual eligible D-SNPs, which cover Medicaid benefits under a capitated contract between the state Medicaid agency and the Medicare Advantage organization, the Medicare Advantage organization's parent organization, or an affiliate. The highly integrated dual eligible SNP covers long-term services and support or behavioral health services. The D-SNP plans also can be coordination only D-SNPs, which are not FIDE or HIDE D-SNPs, and generally have certain obligations to notify the state Medicaid agency or its designee of hospital and skilled nursing facility admissions for certain high-risk, full benefit dual eligible individuals. Private fee-for-service plans. Individuals enrolled in private fee-for-service plans may receive covered services from any provider in the United States who is eligible to provide Medicare services and agrees to accept the plan's terms and conditions of payment. They're not limited to receiving services from a network of plan providers. Some private fee-for-service plans contract with providers, and they do have a network. If the private fee-for-service plan has a network, enrollees may pay more if they see providers that are not in the network. Except for emergencies, enrollees must inform providers before receiving services that they are a private fee-for-service plan member, typically by showing their card so that the non-network provider can decide whether they want to accept the plan's terms and conditions. Non-network providers that accept original Medicare may choose not to accept a private fee-for-service plan enrollee. Therefore, an enrollee needs to confirm that their provider of choice will accept a private fee-for-service plan before enrolling in one. Private fee-for-service plans continue. Providers are prohibited from charging a private fee-for-service enrollee more than the cost sharing specified in the private fee-for-service plan's terms and conditions. Cost sharing may include balance billing up to 15% of the Medicare rate only if allowed in the plan's terms and conditions of payment. Balance billing happens when a doctor is eligible to accept Medicare, but is not a Medicare participating provider under original Medicare. Under original Medicare, these non-participating providers are allowed to balance bill up to 15% over the Medicare payment amount. Private fee-for-service plans may choose whether or not to allow non-participating providers to balance bill their members. Private fee-for-service plans may choose to offer Part D benefits, but are not required to do so. Medicare savings account plans. A Medicare savings account is a high deductible health plan that is combined with a special medical savings account. Medicare contributes money to the beneficiary's medical savings account to assist with paying for Medicare covered services during the deductible phase. The amount of the contribution varies by plan. Money left in the account at the end of the year stays there. If the beneficiary remains enrolled in the plan the following year, Medicare will add new deposits. If a Medicare savings account enrollee uses all of the funds in their medical savings account, they must pay out of pocket until they reach their deductible. After the annual deductible is met, the plan pays 100% for covered services. The maximum allowable deductible for MSA medical service account plans in 2024 is $16,000. However, most medical service accounts will have a substantially lower deductible. There is no premium for a Medicare savings account. Medicare savings account plans cover Part A and Part B benefits, but beneficiaries must continue to pay their Part B premium. Medicare savings accounts do not cover Part D Medicare prescription drug benefits. Medicare savings accounts, MSAs, do not cover Part D Medicare prescription drug benefits. MSA enrollees must enroll in a standalone PDP if they want prescription drug benefits. MSA enrollees may receive covered services from any Medicare-approved provider in the United States if the provider chooses to accept their plan. Medicare savings accounts may not have a network or may have a full or partial network of providers. All non-network providers must accept the same amount that original Medicare would pay them as payment in full. This is the amount the enrollee will pay the provider before the deductible is met. Medicare Advantage plans for employers and unions. Employers and unions may offer their retirees and their dependents Medicare Advantage individual plans open to the public. Medicare Advantage plans that are only available to individuals based on their employer are known as Employer Group Waiver Plans, or EGWPs. A Medicare Advantage plan through a direct contract between the employer or union and CMS is known as a direct contract plan. Employers with less than 20 employees, as calculated under the Medicare secondary payroll rules, may be able to offer Medicare Advantage plans to their active employees and their dependents. Less than 20 employees, someone is eligible for Medicare, the employer may be able to offer them Medicare Advantage plans, even though they're active. Any size employer can offer Medicare Advantage plans to its retirees and their dependents. EGWP and direct contract plans are different than other Medicare Advantage plans because eligibility to enroll is limited to certain active employees, retirees, and their dependents, and because a variety of regulatory requirements are waived as they apply to these plans. Eligibility for Medicare Advantage plans. To be eligible to enroll in a Medicare Advantage plan, a beneficiary must be entitled to Part A and enrolled in Part B. The beneficiary must permanently live in the Medicare Advantage plan service area. If a beneficiary spends 6 months or more outside of the plan's service area, they should only enroll in a Medicare Advantage prescription drug plan with a visitor traveler benefit. The member must be a United States citizen or lawfully present in the United States on or before the enrollment effective date. Medicare Advantage plans must generally enroll any eligible beneficiary who applies regardless of health status. Special needs plans only enrolls beneficiaries within their targeted population. Employer group waiver plans or direct contract plans may only enroll Medicare beneficiaries who are active employees or retirees of the employee or union offering the plan and their dependents. An individual can sign up for Medicare through the Social Security Administration. The following individuals are not eligible to enroll in a Medicare savings account. An individual who receives health benefits that cover all or part of the annual deductible under the Medicare Advantage Medicare savings account plan. Examples include, but are not limited to, primary health care coverage other than Medicare, Medicare hospice, certain supplemental insurance policies, and retirement health benefits. An individual who is enrolled in a federal employee health benefits plan or is eligible for health care benefits through the Veterans Administration is not eligible for a Medicare savings account. Dual eligibles entitled to receive coverage of Medicare cost sharing through Medicaid are not eligible. An individual who cannot provide assurances that they will reside in the United States for at least 183 days during the year for which the election is effective is not eligible for a Medicare savings account. An individual who is currently already elected hospice is not eligible for a Medicare savings account. Medicare Advantage plans may charge a premium. If the plan charges a premium, beneficiaries generally must continue paying their Part B premium in addition to paying the monthly premium to the plan to be enrolled. Medicare Advantage plans may also require their members to pay for a portion of covered services that they receive. This is known as cost sharing. There are several potential types of cost sharing. There's the deductible. Deductible is a set amount the member must pay for covered services before the health plan begins paying for those services. Then there's copayment, which is a fixed dollar amount per service that the member must pay. For example, $20 for each visit to a primary provider or $30 to a specialist. And then there's coinsurance. Coinsurance is a percentage of the cost of service that the member must pay. For an example, 20% of durable medical equipment. All Medicare Advantage plans must have a maximum out-of-pocket limit known as the MOOP for Parts A and Part B benefits. That is, once the member pays a specified amount of cost sharing, the health plan pays 100% of covered medical services for the remainder of the year. Each year, CMS specifies a mandatory maximum out of pocket, which health plans cannot exceed, although many of them have a lower MOOP. Each plan's MOOP will be specified in its summary of benefits and its evidence of coverage. For 2025, the maximum MOOP limit for Medicare Advantage coordinated care plans and private fee-for-service plans is $9,350, although most plans will have lower limits. PPOs which must also have an aggregate MOOP for network and non-network providers of $14,000 in 2025. So it's the PPO in network, the max is $9,350. In and out of net, the max is $14,000. Most plans will be lower than either of those numbers. As previously noted, Medicare savings accounts have a deductible that members must pay. Then the plan pays 100% of their covered services. All Medicare Advantage plans must cover all Part A and Part B benefits. Most Medicare Advantage plans also cover part of the original Medicare cost sharing for Part A and Part B benefits. Medicare Advantage plans may also cover extra benefits not covered by original Medicare, known as supplemental benefits, such as vision services, including glasses, hearing aids, routine dental services. Supplemental benefits may be optional or mandatory. Mandatory supplemental benefits are embedded in the Medicare Advantage plan and must be purchased as part of the plan. They can include reductions in cost sharing for benefits under original Medicare. Optional supplemental benefits may be added to a Medicare Advantage plan at the option of the beneficiary. So some plans will have some supplemental benefits, some additional dental, some additional vision benefits that the beneficiary can purchase. Special benefits depending on chronic health conditions. Medicare Advantage plans may offer special benefits for individuals with certain chronic health conditions, such as diabetes, heart failure, COPD, or other conditions that are not available to members of the same plan without that specified condition. There are two categories of such benefits. Primary health related for chronically ill enrollees may include items such as decreased cost sharing for certain services or supplemental benefits such as an at-home palliative care or transportation to medical appointments.
Calls from Temptation FM.
Special supplemental benefits, benefits that are not primarily health related. The latter generally address social determinants of health and are known as special supplemental benefits for the chronically ill, or SSBCI. SSBCI may include items such as groceries, meals beyond a limited basis, pest control, and non-medical transportation. Medicare Advantage plans may implement mechanisms to manage the utilization of covered services. Such mechanisms include requiring a referral or prior authorization to obtain a service. PPOs may not require prior authorization for out-of-network services. Private fee-for-service plans may not require prior authorization. Non-network Medicare savings account may not require prior authorization. Plans may also implement step therapy requirements for Part B or Part D drugs. Step therapy is when a plan requires a beneficiary to try less expensive options before stepping up to drugs that cost more. When an enrollee has enrolled in an MA plan, a Medicare Advantage plan, after starting a course of treatment, there is a minimum 90-day transition period during which the Medicare Advantage organization may not disrupt or require reauthorization for the active course of treatment for new plan enrollees, even if they are receiving the services from a non-network provider. As previously noted, qualified Medicare beneficiaries are a type of dual eligible beneficiary. Special rules apply to QMBs enrolled in any type of MA plan. When a QMB enrolls in a Medicare Advantage plan, the beneficiary does not have to pay more cost sharing than any minimal copay that would apply under Medicaid. All providers, whether or not they are Medicaid participating or in network, are prohibited by law from balance billing the qualified Medicare beneficiary for any Medicare cost sharing amounts. Providers who balance bill are subject to sanctions. Medicare Advantage and prescription drugs. An organization offering coordinated care, Medicare Advantage plans must offer at least one Medicare Advantage plan with prescription drug coverage, known as MAPD, in every service area. Medicare Advantage private fee-for-service plans have the option of offering prescription drug coverage but are not required to do so. An individual enrolled in an Medicare Advantage private fee-for-service plan that does not include a Part D benefit may enroll in a standalone prescription drug plan, even if under the same Medicare Advantage contract, the organization offers another private fee-for-service plan that includes a Part D benefit. Medicare Advantage, Medicare savings account plans are prohibited from offering prescription drug coverage. If a Medicare savings account member wants prescription drug coverage, the member must enroll in a standalone prescription drug plan. If a beneficiary enrolls in a Medicare Advantage plan that includes Part D prescription drug, the beneficiary can only receive Part D coverage through that plan. If a beneficiary enrolls in a Medicare Advantage plan that is an HMO or a PPO that does not include Part D coverage, the beneficiary cannot join a standalone prescription drug plan. If the beneficiary wants to remain enrolled with the organization offering their Medicare Advantage plan, they must choose a Medicare Advantage plan with prescription drugs. Enrollees in certain employer union retirement plans may have different options. Mrs. Foley is enrolled in We Care HMO's Ruby plan, which does not include prescription drug coverage. She asked her agent about enrolling in a prescription drug plan because she likes We Care HMO but wants drug coverage. Her agent advises her that to remain with We Care HMO and receive drug coverage, she must enroll in We Care's Diamond plan, which is an MAPD plan. She cannot enroll in a standalone prescription drug plan if she's enrolled in the We Care HMO. Other types of Medicare health plans. There are other types of Medicare health plans which are not Part C or Medicare Advantage plans. The other types of Medicare health plans include Medicare cost plans, programs of all-inclusive care for the elderly, PACE, Medicare, Medicaid, MMPs, and other demonstration plans. Other Medicare health plan demonstrations include state-specific demonstrations such as the Minnesota Senior Healthcare Options Program. Medicare cost plans are Medicare health plans that are not Medicare Advantage Part C plans and are not original Medicare. Medicare cost plans may offer Part D prescription drug coverage as an optional benefit, but are not required to do so. Medicare cost plans may offer other optional supplemental benefits. Medicare cost plans are available only in certain areas in the United States. In 2024, they were offered in 11 states, including some counties in Illinois, Iowa, Kansas, Minnesota, Missouri, Nebraska, North Dakota, Oklahoma, South Dakota, Wisconsin, and Wyoming. An individual may enroll in a cost plan and a standalone prescription drug plan. This applies regardless of whether the cost plan offers Part D coverage or not. Oh, let me go back. Cost plan enrollees can choose to receive Medicare covered services under the plan's benefits by going to plan network providers. The plan's cost sharing applies when the enrollee gets services from network providers. Under original Medicare, by going to non-network providers, original Medicare cost sharing applies when the enrollee gets services from non-network providers. This amount is generally higher than the plan's cost sharing. The following individuals are eligible to enroll in a Medicare cost plan: those with Medicare Parts A and Part B, those with only Part B. Enrollees with Part B only will not have Part A coverage under the plan unless they purchase it. The plan may adjust the enrollee premium for individuals with Part B only. Enrollees must pay their Part B premiums and any plan premium as well. PACE plans, programs of all-inclusive care for the elderly. These are Medicare plans for frail elderly beneficiaries certified as needing nursing home level care, but still living in the community. They're not in the nursing home. These are plans that are available in most states, but tend to have small service areas and thus may only be available in a few counties. These are plans that offer an adult day health center where enrollees can get health care, meals, and other services. These are plans that include comprehensive medical and social service delivery systems using an interdisciplinary team approach in the adult day health center, supplemented by in-home and referral services. Eligibility for PACE: participants must be age 55 or older. They must reside in the PACE organization service area, be certified as eligible for nursing home care by their state, be able to live safely in a community setting at the time of enrollment. Under a PACE plan, there's no deductible or co-payment for any drug, service, or care approved by the PACE team of healthcare professionals. Beneficiaries with Medicaid pay no premiums. Beneficiaries with only Medicare pay a monthly premium to cover the long-term care portion of the PACE benefit and a premium for Part D in addition to the Part B premium. Medicare Medicaid plans, MMPs. These are established under demonstration authority and are available only in certain counties. In Rhode Island, South Carolina, Texas, California, Illinois, Massachusetts, Michigan, New York, and Ohio. Only certain individuals eligible for both Medicare and Medicaid may enroll in MMPs. Eligibility varies by state. MMPs financially integrate and provide both Medicare and Medicaid benefits. In some states, MMPs may offer additional benefits. All MMPs include Part D benefits. MMPs are not Medicare Advantage plans. Enrollees, protections, appeals, and grievances. Enrollees of a Medicare Advantage plan, a Medicare cost plan, a PACE plan, or an MMP have a right to file complaints, sometimes called grievances, including complaints about the quality of their care. They have a right to get a decision about healthcare payment or services or prescription drug coverage. They have a right to get a review and appeal of certain decisions about healthcare payment, coverage of services, or prescription drug coverage. The grievance process is used for complaints about the operations of a plan or its network providers. Enrollees or their representatives may file a grievance if they experience problems with their healthcare service, such as timeliness, appropriateness, access to and/or setting of a provided health service, procedure, or item. Grievance issues also may include complaints that a covered health service, procedure, or item furnished during a course of treatment did not meet accepted standards for the delivery of health care. An enrollee or their representative may make the complaint orally, in writing, or via the CMS website. Plans must provide a link to the Medicare.gov website where the enrollee can enter a complaint. Mr. Russell went to an orthopedic surgeon after being referred by his primary care doctor. He sat in the waiting room for 2 hours after his appointment time before being called in to see the doctor. He called his Medicare Advantage plan to complain. The customer service representative told him that she could take his complaint, or he could file it through the plan's website. He opted to file it through the plan website. The plan investigated his complaint and responded to Mr. Russell. Coverage decisions are determinations made by a medical health plan concerning whether medical care or prescription drugs are covered, how they are covered, and the beneficiary's share of costs. An enrollee has a right to ask for prior authorization even when it is not required to find out if a service will be covered by the plan. Here are some examples. Examples of times when an enrollee may need a coverage decision include to get prior authorization for a provider to furnish a service, to obtain payment for certain items or services, such as the type of level of service the enrollee thinks should be furnished, to obtain payment for urgently needed services the enrollee received when they were temporarily out of the area, to continue a service that the enrollee believes is medically necessary, to obtain payment for a prescription drug, to ask for an exception from a plan's formulary requirements, including step therapy requirements or tiering structure for prescription drugs. The appeals process is used to ask for a review of the plan's coverage or payment decisions. Appeals is different from grievance. If an enrollee is not satisfied with the coverage decision, they, or in some cases, their physician can appeal the decision. Physicians can appeal prior authorization denials on behalf of their patients. An appeal is a formal way to ask the plan to review or change a coverage decision. An appeal can also be filed if an enrollee believes the Medicare health plan did not pay for or authorize a service that should be covered. Where the plan did not pay, the enrollee must be financially liable in order to appeal. An enrollee believes an authorized service, such as a hospitalization or home health care, is ending too soon. an enrollee believes a plan has not authorized or paid for a Part D prescription drug that should have been covered. Medicare health plans must provide enrollees with a written description of the appeal process. Medicare health plans offering a Part D benefit must provide access via a secure website or secure email on the website for enrollees to quickly request a coverage determination or appeal a decision about coverage of a drug. Require network pharmacies to provide enrollees with a printed notice with the plan's toll-free number and website for requesting a coverage determination concerning a drug. These are your sources for more information, of course. Your Medicare and You handbook, the 2025 handbook will probably be out around November. You can get more information at cms.gov at either one of these links.
Thank you, Faye.
Oh, you're so welcome.